Good morning, everyone, and thank you for the opportunity to present our results today. I am Dr. Carrie Minnaar, and I'm a radiation scientist, and I'm going to be talking about the results of the phase 3 randomized controlled trial that we conducted at WITS. First, a little bit of background. What is hypothermia in oncology? So hypothermia, for those of you who don't know, refers to the heating up of malignant tissue to above normal body temperature. And this is done for therapeutic purposes. The original goal of hypothermia was to heat tumors to temperatures in excess of 43 degrees. And this is because at these temperatures, protein denatures and necrosis happens. However, heating tumors to these high temperatures became quite problematic. The technology required was complex and expensive, and very often healthy tissues got burned at the same time. So while hypothermia was first used in the early 1900s, over the next few decades, radiation and chemotherapy were developed and became far more popular and effective than hypothermia was as a standalone therapy. So eventually hypothermia became less popular as fewer and fewer people used it. Then in 2005, Professor Dewhurst in the United States did some research showing that mild heating actually has a very, potentially a very important role as a radiosensitizer. This meant that hypothermia could still be used, but at lower temperatures that were much more achievable. And in 2006, the development of the modulated electro-hyperthermia device by Oncotherm opened up doors to a whole new era of research in hypothermia. So now modern hypothermia, following Professor Dewhurst's paper on resetting the biological rationale of heat, modern hypothermia aims to achieve temperatures of between 39 and 41 degrees Celsius in tumors. These are far more achievable, and it allows for safer and more affordable equipment to be used. Why do we want mild heating? Well, at mild temperatures, we get vasodilation, and this increases blood perfusion and oxygen perfusion. And it's important that mild temperatures are used because at temperatures in excess of 43 degrees result in vasoconstriction, and the reduction in oxygen. So why do we want oxygen in the tumor when we irradiate? The oxygen has a very important role in sensitizing the tumors to radiation. There are two different methods that radiation causes damage, by which radiation causes damage. There's the indirect method and the direct method or effect. So the direct effect is when the charged particle interacts with the DNA and causes a double-strand break. The indirect effect is when the charged particle interacts with an oxygen-containing molecule and results in the formation of a highly reactive molecule called a reactive oxygen species. And these reactive oxygen species can cause a lot more damage than just the direct effect. So by increasing the oxygen, we potentially increase the number of reactive oxygen species that are formed in the tumor at the time of irradiation. Then there's another way that the increased oxygen benefits. So the oxygen molecules bind to the double-strand breaks that are caused by the indirect or direct effects. And this is known as the oxygen fixation theory, where the oxygen molecule binds to the double-strand breaks and inhibits the repair processes, slowing down the repair. So this mild heating has two very important effects when we combine it with radiation. It increases the amount of damage done and impairs the repair processes. So there have been various barriers to the uptake of hypothermia in low to middle income countries. Most notably, the cost and complexity, as well as the specialized team you're usually required to administer the treatments. So despite many European and Asian companies having integrated hypothermia into standard of care protocols, we are still limited in low to middle income countries in terms of access to hypothermia. Modulated electro-hyperthermia, as I mentioned earlier, was developed in 2006 by Oncotherm, and it results in a very mild heating. So Professor Lee in 2018 showed that the addition or the use of modulated electro-hyperthermia over cervical cancer tumors resulted in a mild increase in temperature, but a significant increase in blood perfusion. Based on this, we developed protocols to evaluate the clinical efficacy of the modulated electro-hyperthermia compared to various other hypothermia devices that have already been studied in cervical cancer internationally. Okay, this was a very important trial. It was the first phase 3 randomized controlled trial on modulated electro-hyperthermia, and it was the first hypothermia trial to be conducted in Africa. It was also the first hypothermia trial to include HIV-positive women. So we looked at participants staged clinically based on the FIGA 2014 staging guidelines. So they were staged using an abdominal pelvic ultrasound and a chest x-ray, as well as examination and biopsy. And we included patients staged 2B to 3B with distal parametrial involvement. And HIV positive participants were included provided they had a CD4 count above 200 or were on antiretroviral therapy for more than 6 months. We randomized using an online randomization tool with HIV status as a stratum. And participants received either chemoradiotherapy with or without the hypothermia treatments. Standard of care chemoradiotherapy in our institution was 50 grays of external beam radiation, 3 doses of 8 gray HDR brachytherapy, and 2 doses of cisplatin at 80 milligrams per square meter. Okay, we were then fortunate enough to receive funding for additional PET-CT studies. So once participants had enrolled, and we then had the participants imaged with a PET-CT. We used the PET-CT studies to evaluate tumor response, and it's very important to note that we didn't adjust the staging based on the PET-CT studies. We also looked at local disease control at 6 months and survival at 2 years. The original plan was to follow the participants up for 2 years post-treatment. It was difficult to blind the participants as to which treatment they were receiving, but what we did do is blind the nuclear medicine physicians who were reporting on the PET studies. So they received the studies at 6 months, and they had no idea which group the participants were in. Okay, the hypothermia was administered twice per week, immediately before radiation, and for 1 hour. So the results we've published in various journals, all peer-reviewed, and we've also won some awards, the most prestigious of which was from ESTRO in 2021 for our 3-year survival results. Okay, a total of 271 participants were screened, and 210 participants were enrolled. So at 6 months post-treatment, we looked at safety. There were no dose-limiting toxicities from the hypothermia treatment, and we had very high compliance to the treatment. Toxicity directly attributed to the hypothermia, we had a grade 1 to 2 adipose burns in 10% of the participants, and these occurred in participants with a BMI over 30. They manifested as a small hard nodule that was sensitive, but it was not treatment dose limiting. It was managed with analgesics. And we had one participant with a small blister develop, and some participants complained of pain during the treatment. However, when we adjusted the settings, the pain was alleviated. We looked at early toxicity and the effect of the addition of hypothermia on radiotoxicity and chemotoxicity. We also looked at late toxicity at 3 years and at 5 years, and there was no difference in toxicity profiles for the chemotherapy or the radiotherapy at 6 months or 5 years between the two groups. There was also no difference in toxicity between the HIV positive and negative participants in the hypothermia group. Then local disease control at 6 months post-treatment was almost doubled in the group that received the modulated electro-hypothermia. And 2-year and 3-year disease-free survival was also significantly improved. As I said, we initially planned to monitor participants for 2 years, but based on the positive 2-year survival results, we applied for an extension to follow the participants up for 5 years in total. We looked at quality of life at 2 years post-treatment, and as you can see, 10 out of the 11 scores were significantly improved in the hypothermia group versus only 5 out of the 11 in the control group. Then using the quality of life results and disease-free survival results, we performed a cost-effectiveness analysis using a Markov model, and we showed with 82% probability that the use of the technology in a public hospital, in our public hospital, would save the hospital money over a 3-year period with an 82% probability. This is because there's fewer recurrences and residual disease requiring the more expensive second-line treatments, and less morbidity and mortality. We also showed, we extrapolated the data into a private healthcare model and showed with a 78% probability that the use of the treatment could save medical schemes money over a 3-year period. It's also very uncommon that a new treatment in oncology actually saves money whilst being more effective. So yeah, it was interesting that we could see the addition of the hypothermia to chemoradiation dominated the model. Then we followed the participants up for 5 years, as I said, and we showed that the 5-year disease-free survival was more than doubled. So the disease-free survival remained consistently high over the 5-year period. When looking at overall survival, the difference was only significant in the stage 3 group. We then had a very interesting experience or subgroup. When we looked at the PET-CT studies at 6 months post-treatment, we saw that in fact 108 of the participants had extrapelvic disease on the pre-treatment PET studies, which we hadn't seen during the staging workup. There were 54 participants in each group with extrapelvic disease or stage 4B disease. And interestingly, in the group that received the hypothermia treatment, a quarter of the participants at 6 months showed complete metabolic resolution of all disease, extrapelvic and pelvic disease. So we obviously ran a few analyses to determine the most likely cause of this, and this response was not significantly associated with the number of chemotherapy doses or age or radiation dose or any other variable except for the hypothermia. And interestingly, we saw this response equally in the HIV positive and negative participants in this subcohort. So we hypothesized that this is a potentiation of the abscopal response by the modulated electro-hyperthermia. We followed the participants up for 5 years and saw that most of the participants who had this potential abscopal response remained disease-free at 5 years, with the exception of 2 participants who passed away from non-cancer related causes. So this seems to be the potentiation of a systemic response and most likely an immune-mediated response, as it's most widely acknowledged that the abscopal response is due to an immune response. So to conclude, the addition of modulated electrohypothermia added to the management of cervical cancer in our setting resulted in a significant improvement in local disease control, 5-year disease-free survival. It was cost-effective, did not alter the toxicity profile, and potentially promoted a long-term sustained immune response to disease when combined with radiation therapy. Obviously, a study of this size requires a dedicated team, and I'd like to thank the Department of Radiation Oncology and Nuclear Medicine at Charlotte Macleod Johannesburg Academic Hospital, as well as my supervisors and co-PI, Dr. Jeffrey Kotson and Prof. Ans Baines, and anyone who knows what it's like in the resource-constrained setting will understand how important the participants are and how difficult it is for them to show up regularly for all their follow-ups with courage and grace. And so without the participants in the study, this wouldn't have been possible. So big thanks to them. And then thank you to all of you for listening. I hope you enjoyed the talk. And yeah, thank you very much.